Before we talk about the treatment, I'd like to introduce the team behind the treatment, a group of dedicated scientists, embryologists, nurses, admin staff, and doctors who work really hard to make sure that your treatment is as successful as possible. Before we talk about IVF treatment, I'd like to briefly talk to you about what happens in a natural cycle and how conception occurs normally. And as you can see here on the screen, this is the ovary, this is the fallopian tube, and that's the womb. And ovulation occurs once a month, and if intercourse takes place around the same time of ovulation, then you could see that the sperm could meet the egg in the fallopian tube, and fertilization will take place in the outer third of the fallopian tube. The resulting embryo will move backwards toward the lining of the womb where it implants. So only one egg is produced per month, and therefore multiple pregnancy is uncommon. In an IVF cycle, the situation is slightly different. We use medication, usually hormone injections, to stimulate the ovaries to produce multiple eggs. Fertilization does not occur in the tube, it occurs in the laboratory dish under controlled conditions. And because we fertilize more than one egg and possibly transfer more than one egg after fertilization, then the risk of multiple pregnancy is higher. And I will talk to you later on in the evening around how we are trying to reduce the multiple pregnancy rate, but still keep your success rate as high as possible. So what do you need to do before your first visit to the clinic? First of all, please have a look at our booklet, which contains a lot of information regarding the various forms of treatment that we offer. Our clinic offers a comprehensive range of fertility services, both diagnostic and treatment related. So have a look at the booklet, please. We also have a website, ivfdirect.com, lots of resources on the website which you hopefully will find helpful. As I said, we offer a comprehensive range of fertility treatments, including IVF and ICSI, PGD, ovulation induction, egg donation, surrogacy, fertility surgery, fertility preservation, and of course IUI, or intrauterine insemination. Just a brief word about IUI. We offer it for couples who might have a problem with ovulation, or they have no identifiable problem to cause the subfertility, or there might be some problem with intercourse. We also offer it to same-sex couples who request fertility treatment. The success rate per IUI cycle is approximately around 15%, and some of the IUI cycles could be funded by your PCT, but we need to establish that based on your PCT and whether it's allowed under their criteria for funding or not. And we can establish that when we meet for the first time in the doctor's appointment. So what do you need to do to prepare for the IVF treatment? First of all, please, if you do smoke, please stop smoking, reduce your alcohol consumption, and for the female partners, please carry on or start, if you haven't already, taking the folic acid supplementation. With regard to weight, if you think that you need to lose a few pounds, then this is probably the right time to do that, and we will also guide you through that process when we meet in the first consultation. The initial consultation is an hour-long discussion with your doctor in the clinic. Prior to the consultation, we will ask the male partner to produce a sperm sample, the result of which should be available at the time of the consultation. We will take medical history from both partners. We will do an examination and an internal scan for the female partner. We may also need to examine the male partner. We will arrange for you to have some blood tests, and we'll ask you to sign some important consent forms. The consent forms are generally related to the treatment and also to satisfy our obligations towards the regulator of the IVF sector, which is the Human Fertilisation and Embryology Authority. Please complete your consent forms and bring them to the appointment, but do not post them. Please bring them yourself to your first appointment. The consents related to treatment will cover the hormone injections to stimulate the ovaries, the procedure of egg collection, which is done under sedation, and I will talk to you about it in detail later on. It will cover the fertilization process, whether with IVF or ICSI, and it will also cover the process of transferring the embryo or the embryos into the womb cavity. We will also ask you to consider storing and freezing surplus good quality embryos, and we have a good success rate with our frozen program, and I will also touch on that later on in the talk. We can freeze initially the embryos for up to 10 years as per the consent forms. There will be consent forms for possible research and training according to your wish, and we will discuss that with you at the time of the initial consultation, and also provide you with some background information about the research activities that we have in the clinic. Just something to think about. What if we freeze or store any eggs, sperm or embryos for you, and then something happens to either of you? What would you want us to do with the stored eggs, sperm or embryos? So just something to think about prior to the appointment, but we will discuss that in more detail with you when we meet in the initial consultation. Now I'll hand you over to Chantel, one of our excellent nurses, who will talk to you about starting a new treatment cycle. Thank you.
Hello, good evening everybody. My name is Chantel Dunn and I'm one of the senior nurse practitioners within ACU, and I'm here to just introduce you to starting your treatment cycle. I'd like to start off by letting you know that before you get to this stage, you'll actually have had your consultation with one of the senior doctors, and they will actually inform you as to what treatment type that you'll be going through. So when it actually comes to starting your treatment cycle, we will invite you to contact the ACU nurses. Now, if you've been told that you are on a standard long protocol, you'll be invited to email the nurses at ivf.nurses@gstt.nhs.uk. We will ask you for the details that are up on the board, so you'll send that in your email, and you will actually get a response within about 2 days to 5 days from one of the nurses, just letting you know about a schedule appointment. If you are on a short cycle, please can we ask you to call the nurses 2 to 3 weeks before your next period is due, so that we can offer you this schedule appointment and also actually request your medications to be delivered before your period is due. Now, the personal schedule appointment is a 20 to 30-minute chat with either myself or one of my colleagues to run through the full details that you'll need for your treatment cycle. So we will go through basic identification information. We will make sure that your consent forms are completely filled out and that we've specified all the details needed for the treatment cycle. And we'll also make sure that you've received your medications in a timely process to make sure that once we're ready to start treatment, you can start. Now, the first medication that I'd actually like to introduce you to is for the patients on the long cycle. The first medication will be your nasal spray or down regulation. This is started 21 days after the first day of your period. And as you can see from the picture, it's in the form of a nasal spray. And we will ask you to use 1 sniff into each nostril twice a day. You'll be coming to see one of the nurses, so we will explain this in full detail to you when you come to the actual appointment. But the nasal spray can sometimes have some side effects. So you may find that you get some headaches and hot flushes during the time that you're using your nasal spray, but these side effects will be short-lived. Once you actually get onto injections, your side effects should dissipate. Now, you'll come for a scan appointment before you actually start using the injections. And we generally use 2 forms of injections, a pen called Gonalef or a vial and powder solution called Menopure. Your doctor will actually specify to you which drug that you'll be using before you come to the nurse's appointment. These are injectable medications that are used to stimulate the ovaries, and they're injected daily. and the nurses will teach you at your scan appointment how to use these injections. So please do decide between yourselves who will be giving these injections, so that if you do need to attend together, you come together and you can be both taught how to use them. Generally, we ask you to use your injections for about 8 days before we ask you to come back for another scan. However, there are some of you who will need more scans and maybe even some additional blood tests during the time that you're using these injections. And again, your doctor will inform you if you actually do need these additional appointments. What I've got up on the board at the moment is a scan picture from a routine day 9 scan. What you can see that's pinpointed by the red crosses is a follicle. Now, the follicles are the fluid-filled sacs that we hope to contain eggs when we come to egg retrieval. And what we're looking for at this scan appointment is to see if we have any of those sacs that have reached 18 millimetres in size or more to know that you're ready for egg retrieval. If you have follicles at 18 millimetres or more, this may suggest that if there are eggs inside them, they are mature enough to be fertilised, and therefore we should be getting you ready for your egg retrieval in roughly 2 to 3 days' time. If we haven't reached that size at the day 9 scan, that doesn't mean that we're not ready or we're not going to proceed to egg retrieval. It just means that you need another 2 or 3 days worth of injections before we see you again for another scan appointment to check your progress. So I've got 3 pictures on the board at the moment which just show some of the responses that you may have to your injection medications. The top picture shows a poor response. We can see that there are few follicles on the ovary and that they are quite small in size. If we do see this at your day 9 scan appointment, it does not mean that your egg retrieval will be cancelled in all cases. However, what we've seen here is that we have had what we would term as a suboptimal response to the medication. In the middle picture, we've seen a good response. The ovary looks almost like honeycomb, and the follicles on the ovaries are a good size. On the bottom picture, you can see an over-response to the medication. There are many follicles there. And in some cases, what we may actually do is ask you to consider cancelling your treatment cycle, as the risk to your health is outweighed when we actually trigger you for egg collection in this circumstance. Now, there are 3 outcomes to your day 9 scan. If we see a good response and the follicles are all of a good size, we may then choose to plan your egg retrieval. However, if you've got a slow or poor response, you may be asked to continue your injections for a few more days and come back for another scan. However, if we see an extremely poor response or over-response, we may ask you to cancel your treatment cycle. And as I've said before, there are some couples who may need to come back for extra blood tests and scans during the time that you're using your injections. Now, I just want to give a separate word to over-response. We generally use the term ovarian hyperstimulation when we're talking about a severe over-response to your medications. We may need to choose to cancel your cycle, as I've said before. However, there are some cases where your doctor may choose to trigger you for the egg collection, collect the eggs, possibly form embryos, but then ask you to defer the transfer of your embryos until your body has recovered from the ovarian stimulation. Now I want to move on to talking about your trigger injection. This is the injection that we use once we know that you're ready for egg retrieval. You'll be given strict instructions as to the day and time of day to use this trigger injection, and what it actually does is matures the eggs inside the follicles. Routinely, it's given 36 to 40 hours before you come in for your egg retrieval, and therefore you can see the importance of giving it at the right time and the right day also. So, for example, if you were to give this injection at 8:30 p.m. tonight, Wednesday, we would ask you to come in and be ready for your egg retrieval at 8:30 a.m. on Friday morning. So you see now how important it is to get the day and the time correct. Once you've given this trigger injection, you will have 1 drug-free day, and the nurses will prepare you by asking you to stop eating and drinking roughly 6 hours before you attend the unit for the actual egg retrieval. I'm going to now hand back over to Mr. El-Tuki to talk you through the process of egg collection.
Okay, so by now, when you're ready for egg collection, you will have had the initial consultation with the doctor. came and saw the nurse for the scheduling appointment, then contacted the clinic on day 1 of your period, started the medication, had the hormone injections to stimulate the ovaries. The ovaries responded well, and we gave you the HCG or the trigger injection, and you're ready for egg collection. And although we emphasize the risk of cycle cancellation, we actually cancel very, very few cycles, probably about 2 or 3% of all the cycles we do. So it's not a very high risk, and in the majority of cases, there will be decent ovarian response to allow for egg collection to proceed. Now, on the day of egg collection, we will ask you to have had nothing to eat or drink for approximately 6 hours prior to the procedure. The procedure itself is done under deep sedation in a controlled theatre environment. So you will be asleep during the procedure, and therefore there will be very little discomfort afterwards, and hopefully no discomfort during the procedure at all. The procedure is done under ultrasound guidance, and as you could see on the screen, this is a well-stimulated ovary, and you can see the white line here represents the needle going through the vaginal skin from down below, which, as I said, you don't feel the needle going in because you're sedated. And then the needle will enter the first follicle to empty it, suck the fluid out using very gentle suction, and then we move from one follicle to the next, sucking the fluid out of each follicle, and then pass that fluid on to our colleagues in the embryology lab to find the eggs in that fluid. When we finish the first ovary, we take the needle out and reinsert it to collect the eggs from the second ovary. The whole procedure takes approximately 10 minutes, possibly less than 10 minutes, and you wake up pleasantly with no nausea or discomfort, and you spend about an hour or so in our clinic, have a cup of tea, biscuit, recover nicely, and then you go home after that. We have very nice recovery bay, good views, and we try as much as possible to make it a pleasant experience for you. Because you will have had sedation, we would ask the male partners to accompany you home and stay with you during the day, and we would also advise you not to cook or operate any machinery on that day because of the effect of the sedation. So what happens after egg collection? We will ask you to start taking progesterone supplementation, which is a natural hormone that renders the lining of the womb more receptive for the embryo. So it helps the process of implantation, and we will ask you to use some vaginal or rectal pessaries twice a day. Now, you might be wondering what would happen to the eggs in the laboratory, and my colleague, Dr. Bolton, who is the head of the laboratory in our clinic, will talk to you about that.
Good evening, ladies and gentlemen. Yes, this is the bit you've all been waiting excuse me, the bit you've all been waiting for. You're going to find out what happens behind those closed doors in the laboratory. So, this is one of my colleagues. She is looking, as you can see here, there's the Petri dish. She's tipped the fluid that Mr. Al-Touki told you about, that's sucked out of the little sacs of fluid in your ovaries. The fluid is tipped into a Petri dish, and we look down the microscope to see if we can spot an egg in there. If we find an egg, we rinse it free of any of the blood-stained fluid and put it into a fresh dish of this nourishing fluid that contains all the nutrients that the eggs will need for culture, and we keep the eggs warm at body temperature throughout the process. So the eggs are kept on a warm microscope stage, and we put them into the incubator as quickly as possible to keep them at room temperature. Before we embark on this entire procedure of egg collection, we have a very rigorous witnessing procedure which carries on throughout your entire treatment. From the moment you're taken, the female partner is taken into the egg collection theatre, 3 of us will have to ask you to state your name and date of birth, and we make sure that that name and date of birth and your unique identifying number matches every single dish and tube that we use throughout your treatment. And we have a wonderful electronic witnessing system which uses radio frequency identification tags. And it means that every single dish that we use for you is assigned to you as an individual, and it matches your partner and you and your partner only. And if any other dishes come into the vicinity of the dishes that are tagged to you and your partner, all sorts of alarms will go off. So we're very, very careful about making sure that we mix the right eggs with the right sperm, and the right embryos go into the freezer under your names, and they go back into your womb after your treatment is complete. So the eggs, when we're looking in these Petri dishes, the eggs themselves you can't see with the naked eye, but this blob of grey mass that you can see here is like a blob of jelly that you can actually see with the naked eye, but the egg is inside this darkened section here. The egg itself is about 1/10 of a millimetre in diameter, so you can imagine we can't see it with the naked eye, but we collect these blobs of jelly-like cells, and we look for the denser blob in the centre. You can focus up and down and look to see if there's an egg there. And we will put the eggs, as I said, into dishes assigned to you as an individual patients, uniquely assigned to you, and we culture them in the laboratory. So this is just one view of our laboratory, which is it's a long room containing many, many incubators. Here are the incubators in which we will hold your eggs prior to mixing them with the sperm. And here you can just see one of our microscopes, which has got a complicated set of joysticks and micro-manipulators for doing clever and intricate things with your eggs and sperm. Now, as for the sperm samples, the vast majority of you will be asked to produce your samples by masturbation, and we have 2 rooms in which you can produce the samples, and we have done our very best to make the whole process as to reduce the embarrassment that obviously this whole process is likely to engender by making the rooms, they're both tucked away in a discrete area. When they're occupied, a red light comes on in reception and in recovery, so staff know if the room is occupied, so you're unlikely to have anybody come and bang on the door to try and get in. We have a very unique system for transporting the samples from the production room into the laboratory, which means that you don't actually have to set face and make eye contact with anyone after you've done the deed. You simply put your sample in one of these capsules, and the capsule is placed into the transporter. You will be shown how to do it. It's totally simple. There's a green light when everything's going fine, so you needn't worry. It's not complicated. Provided you follow the simple instructions, do not put this capsule into a plastic bag because it relies on friction to get it through the vacuum, and if you put a slithery plastic bag on the outside, the whole system seizes up. So please, that's just the one thing to remember. Hopefully you will be reminded on the day of your egg collection when you produce the sample or partner's egg collection, just follow the simple instructions, and the whole thing is designed to make the whole process as pain-free and as least embarrassing as possible. There are a very small number of you, possibly in this audience, who don't actually have any sperm in your semen, and this will have been identified well in advance of your partner's egg collection. So it may be necessary to perform a minor surgical procedure in order to collect sperm from your testicles. Now, this is not as big a deal as it sounds, and like your partner, your female partner, you would be asked to starve for a few hours before the procedure. We would know well in advance that this was necessary, that we would need to perform the procedure. And obviously you would be sedated, so you wouldn't feel discomfort. But the most important thing to remember is if this applies to you as a couple and your partner's having egg collection, you're having sperm collection, then you will need a third person, a friend who hasn't been subjected to sedation, to take you home. You can't go home on a train, or certainly not drive. You really need somebody to be with you just to make sure you get home safely. And then once you get home, don't start doing the ironing or mowing the lawn. You need to just rest and take it easy. Now, semen samples arrive in the laboratory using our special chute system that I described, and are immediately assigned to you with your unique identifying number, with 2 people witnessing to confirm that everything matches as it should do. So this is what we're looking for. We're looking for little motile sperm in the ejaculate. We look down the microscope, and the normal count is about 20 million sperm per mil, so we're looking for at least that number. We're looking for at least 40% of them swimming around in this vigorous way. And we also look on a higher magnification at the shape of the sperm heads, because we want your sperm, a good percentage of your sperm, to have a normal tadpole shape. And there are various abnormalities that you can see. So a normal count should be about 20 million per mil. Normal percentage moving should be about 40%. And surprisingly, the normal sperm, normal with a sperm normal head is only about 4%. So 96% of your sperm can be abnormal, and that's considered perfectly fine. So provided your sperm fulfill these normal criteria, we would simply wash it, prepare the semen sample with a special sort of spinning and washing and filtering system that we have to concentrate in a very small pellet all the good, healthy, vigorous swimming sperm. And for IVF, we simply take a tiny, tiny volume of that suspension of vigorous motile sperm and add them to the eggs in the afternoon and leave them overnight. And that's all we do. We simply just prepare the sperm, mix them with the eggs and leave them to it. And everything's fine. We come in the next day and look to see how many of the eggs are fertilised. So this is an egg to which have been added millions and millions and millions of motile sperm. And however, if the sperm are not very vigorous and we're a bit worried about the possibility of them fertilising on their own, we don't just squirt them in and leave them to it. We actually physically introduce a single sperm into each mature egg. And here you can see the sperm going down the needle. This is a procedure called ICSI, or Intra cytoplasmic sperm injection. And this is the micro manipulator I told you about. So we have micro needles, this is a micro holding pipette, so a little blunt glass needle with a vacuum, a suction applied to hold the egg securely while we inject a single sperm into each mature egg. So even if you've only got tens of sperm in your ejaculate, provided we can find 10 motile sperm to match 10 mature eggs, we can achieve fertilisation. You have a chance of having a baby. So the old idea of 20 years ago when you needed 20 million sperm per milliliter of semen, it doesn't matter anymore. Provided we can get motile sperm either from the ejaculate or even from your testicles with surgical sperm collection, we can get fertilisation. And if we can get the eggs fertilised, you're in with a fighting chance of a pregnancy. So things have definitely improved over the last few years. So whether or not we add the sperm and let them fertilise on their own, or we inject the sperm, what happens then is we all go home and have a good night's sleep, yourselves and ourselves included, come in the morning to look and see how many of those eggs have fertilised. So the next morning we check all the inseminated for IVF or injected for ICSI eggs, and we phone you up and tell you how many of the eggs have fertilised. This is what a fertilised egg looks like. I don't know if you can remember the other picture I showed you. So here's your 1/10 of a millimetre diameter. There are some sperm stuck on the outside from IVF insemination, but one sperm has got in and it's formed its own little nucleus here containing the man's genes, and here's the egg's nucleus containing the woman's genes. So here we've got an embryo for the first time. And this is the earliest stage of development of the fertilised egg. So we look to see how many of the eggs that we collected for you have fertilised and look like this, and we telephone you to give you the good news. What we then do is we give you an appointment to come in for your embryo transfer. And this appointment will usually be provisionally for day 3 after your egg collection. So day 1 is the day we telephone you. Day 2 is a day of rest for everyone while the embryos continue to develop in the incubator, and we give you an appointment to come for your embryo transfer on the morning of day 3. And overnight, as I've said before, we look for fertilisation to have taken place for day 1. Day 2, we see the embryos start to divide. So by day 2, we'd hope it would be a 4-cell or even an 8-cell stage. Oopsie daisy, 8-cell stage. But by day 3, it would certainly be at the 8-cell stage, we would hope. So what we would do then is, on the morning of day 3, despite the fact that we've given you a provisional appointment, we will call you to either confirm that we would indeed like you to come in and keep that appointment, or we may decide to delay the transfer until day 5, 2 days later. So you have to be prepared for that phone call. The decision that we make as to whether to keep the embryo transfer appointment on day 3 or to delay it to day 5 is based upon whether or not we feel confident we can select the embryo or embryos most likely to lead to a pregnancy. So we're trying to give you the best chance of a pregnancy, and ideally with a single baby. If we feel it's absolutely abundantly clear on day 3 which is the embryo or embryos that have emerged from the group that you might have of several embryos in culture, that's the best, the most healthy, the one that's developing the most strongly, then there's no point us waiting till day 5, and we'll ask you to come in for day 3 transfer. If you've got several embryos and it's impossible for us to select which one we think is the best, they all look the same, we will ask you to wait till day 5. So that's what happens on your day 3 phone call. How many embryos you have, the quality of the embryos you have, will all depend on any number of factors, and all relates to you and what's happened to you and your journey through this treatment. And that will also affect how many embryos we decide to transfer. So the embryos are graded on day 3 and on day 5, and based upon all the different factors, your age, the number of treatments you may have had, how many embryos in the cohort, how many of those embryos look so good that we find it impossible to choose. These are all the factors that will help us to decide whether we would recommend to you that we put back 1 or possibly 2 embryos. In the majority of cases, certainly for patients having their first treatment cycle and who are relatively young, under the age of 37, we would recommend a single embryo to be transferred.
Okay, so you've arrived into the clinic for your embryo transfer. And embryo transfer procedure is a lot simpler than egg collection, so sedation is not required. It's like a mini smear test, and we do the procedure in a very gentle way to ensure that we don't provoke any discomfort or pain. And the idea is to deposit 1 or 2 and occasionally 3 embryos into the lining of the womb. We use a specially designed catheter for that, and as you could see here on the screen, that yellow rim indicates where the womb is, and there's a paler shed in the middle here, in the middle of the womb, and that's the lining of the womb. And then you could see 2 bright spots just in the center of the thicker part of the lining of the womb, and those 2 spots represent the embryo surrounded by a tiny, tiny drop of culture medium. This is a short video showing you what happens during embryo transfer. This is the catheter loaded with the embryo, and then the embryo, as you can see in a moment, will be deposited into the thicker part of the lining of the womb here, and it will be left in the right place, and then we will check the catheter after the transfer, after we withdraw the catheter out, to ensure that indeed the embryo has left the catheter and is definitely in the right place. As you can see here on the screen, that big black area represents your bladder, which we would ask you to have a little bit full to allow us to see the womb with ultrasound through your tummy transabdominally, and it also helps to facilitate the process of embryo transfer itself. We will remind you about the full bladder nearer the time. So what should you do after embryo transfer? Basically continue with your normal routine, carry on taking the progesterone pessaries, which you will have already started from the day of egg collection onwards, and then we will ask you to do the pregnancy test at home on a specific day, which is exactly 16 days after the day of egg collection, and to contact the clinic with the result hopefully positive. I get asked that question a lot: how many visits will your treatment involve? Usually around 7 or 8 visits, but as Chantel indicated earlier, some of you who are considered at higher risk of ovarian hyperstimulation syndrome will be asked to make a few more visits to the clinic during the stimulation phase to ensure that we monitor your response and reduce the risk of hyperstimulation. So when we contact you or you phone us with the pregnancy test result, it's either one of 2 outcomes. Either the outcome is positive, in which case we will arrange for you to come back in 2 to 3 weeks' time to have a pregnancy scan to ensure that the pregnancy is developing healthily and is in the right place, of course. Unfortunately, some of you will not have that positive result, in which case we will encourage you to come and meet one of the senior doctors to discuss how your cycle went and how we can make it better for you next time. I think this is probably the most important slide tonight. It tells you what happens to typical 100 couples coming through treatment in our clinic. The majority of the couples will actually start the treatment and reach egg collection. As I said, only 2-3% will not reach egg collection, either because of poor ovarian response or occasionally over response. The majority of those having egg collections will actually have embryo transfer, but some won't, either because no eggs were found, the eggs were of poor quality and did not fertilize, with no sperm available on the day, or the embryos were developing poorly and therefore not suitable for transfer. However, the majority of couples having egg collection will actually reach embryo transfer with at least one embryo. Half of those having embryo transfer will get a positive pregnancy test, and unfortunately the other half won't. The majority of those of you having a positive test will have a baby 9 months later. Some pregnancies may miscarry or become an ectopic pregnancy. We'll talk about that in a few moments. This represents the success rate of the treatment, and as you can see, it's heavily dependent on female age, so it declines with advancing female age from approximately just above 50% if you're under the age of 35 to about 1 in 7, 1 in 8 if your age is between 43 and 44. So the question is, why can't we get 100% success rate? There are a number of factors behind that. Primarily, these factors are related to the quality of the embryo. So they're embryonic factors. Either the embryo stopped to grow after embryo transfer, or it continued to grow for a little while, established implantation, but didn't have enough potential beyond that stage to continue to develop to a healthy pregnancy. There might be some other factors which could reduce the overall chance of achieving a pregnancy, such as the presence of womb fibroids, which are a collection of fibrous tissue and muscle in the wall of the womb. Could be that the fallopian tube is blocked and swollen and distended with fluid, which could also affect the results of your treatment. And we will tell you if you have any of those factors. Occasionally, the lining of the womb itself might be thin and not able to grow and develop to reach the stage where the lining is receptive to the embryo to allow it to implant. We do have counselling facilities in our clinic, which I'm pleased to say are free and confidential. They can be offered to you as a couple or separately as individuals. Sometimes counselling is mandatory, particularly if you're using donor sperm or eggs. What about the side effects of the treatment? Generally, IVF is a low-risk treatment. We talked about the side effects of the medication, particularly the nasal spray, and the hyperstimulation syndrome, which could result from over-response to the hormone injections to stimulate the ovaries. And if, as I said, if we think that you're at an increased risk, we'll ask you to come in for some extra monitoring during the stimulation process to minimize that risk. Hyperstimulation involves marked enlargement of the ovaries, feeling bloated, distended, nauseous and unwell. Occasionally, we might need to keep you in hospital for a few days to look after you while the symptoms of hyperstimulation subside. The good news is that it's a self-limited process, and in the vast majority of cases, either it doesn't happen or it resolves very quickly. There is a 1 in 500 risk of introducing infection at the time of egg collection or embryo transfer. And again, if we think that you're at an increased risk of that, we will cover your egg collection with antibiotics. Multiple pregnancy, I will speak about in a few moments. But as I said, IVF pregnancies are just like any normal, natural pregnancy. They could miscarry or become an ectopic in the fallopian tube. Now let's discuss the issue of multiple pregnancy. We know that multiple pregnancy occurs at a higher rate in IVF treatment compared to natural conceptions, but we also know that there are increased risks to the mother and the baby from multiple pregnancy, and as you can see on the screen, there are risks of late miscarriage, difficult labor, need for cesarean section and blood loss to the baby. Of course, the major risk is preterm birth, and that could increase the risk of early death or mental disability. So we really are very keen on making sure that whatever pregnancy you achieve with us is as healthy as possible. We know that the main problem with multiple pregnancy is that 50% of twins will be born prematurely and 10% will be born very prematurely, and that's under 32 weeks. And that, as I said, would increase the risk of early neonatal or baby death, and could increase the risk of disability later on in life. So the question is, should we transfer 1, 2 or 3? I think if you're under the age of 40, then it's only either 1 or 2. Only female partners 40 and above are allowed to transfer 3 in exceptional circumstances. So we transfer 1 embryo only if there is a good chance of achieving pregnancy and a higher risk of multiple pregnancy, and that's predominantly in women under the age of 38. We transfer 2 embryos when we're less confident about embryo quality. So we know that they are good embryos, but perhaps the quality is not top grade, and therefore we would counsel you regarding transfer of 2 embryos to increase the chance of pregnancy, but without taking on a huge risk of multiple pregnancy. What gave us confidence in transferring a single embryo and achieving a very good success rate without the attendant risk of multiple pregnancy is the development of blastocyst transfer. So as Dr. Bolton said earlier, if we assess your embryos on day 3 and they are doing well and there are a good number of them, then we would allow them to grow in the laboratory until day 5, and on day 5 we select the best embryo that has reached the blastocyst stage, and we know that transferring a single blastocyst would give you a very good chance of pregnancy and live birth, and again without the risk of multiple pregnancy. We did a lot of research on that and published a paper a few years ago demonstrating that transferring a single embryo could maintain a good success rate and at the same time minimize the risk of multiple pregnancy to your treatment. And as you could see here, we achieved very good success rates with transferring blastocyst in your IVF treatment, and you can see the good success rate maintained even in age groups above the age of 40. So if we're going to transfer fewer embryos, then what do we do with the remaining ones? Well, if they're good quality embryos, then we would discuss with you freezing and storing those embryos for future use. If they're not good quality, then we'll talk to you about disposal of the embryos. And of course, if your wish is to allow them to be used for research or training purposes, then we will oblige. Just a quick word about embryo freezing. We have very good survival rate of frozen blastocyst, approaching 90%. It's a simpler and cheaper treatment than starting a new fresh cycle, and some of you might have the storage of the embryos and subsequent use in a frozen embryo transfer cycle actually covered by your NHS funding. We have very good success rates with our frozen program, which are above the national average for using frozen embryos per age group. And we're proud of that, and we have done a huge number of frozen cycles, and we continue to value the freezing program as an integral and important part of the service we offer to you, not just to make your treatment safer, but also more successful. You can see with the frozen embryo transfer, you have a very good chance of achieving a good success rate with a positive fetal heartbeat on scan, with the data comparing our success rate with the national average. Quick word about research and development. We do a lot of research in our clinic and value that part in advancing our understanding and of the process and how we can make it more successful. We look into how to improve ovarian response in patients who perhaps do not respond very well to the medication. We want to understand more and better about embryo development, and we also do a lot of research on identifying genetic disorders in pre-implantation embryos. However, what I really want to reassure you about is that all our research projects are licensed by the regulator. We are inspected regularly for the rigor of our research to ensure that we are doing it appropriately and scientifically. And most importantly, embryos used for research are never used to treat other patients. We also train a lot of scientists, embryologists, nurses and doctors, and we want to ask you for your help in that process, which are all recognized training programs in our clinic. Now to the nitty-gritty bit. How much does it cost? Many of you will have the treatment funded by their PCT, and as I said, the funding may extend to cover the frozen cycle and embryo storage. And if your fresh cycle is covered by your PCT, that will also include covering the medication required for the treatment. However, some of you will have to self-fund the treatment, and the self-funding will involve the cost of the IVF ICSI treatment, the cost of the medication required for the treatment, and also the cost of freezing, storing the embryos and using them later on in a frozen embryo transfer cycle. The aspects of care are similar to the NHS-funded care as well. Now, how to contact us on day 1 of your cycle? You send us an email to ivf.nurses@gstt.nhs.uk. We will respond to you within 48 hours, and we will respond to urgent calls more quickly than that. We also have an out-of-hours mobile number which you can access for medical emergencies only, and I urge you to please only use it for medical emergencies. This number is always carried by one of our team, weekends and out of hours, and you're more than welcome to use it for medical emergencies only. I've come to the end of the talk, and again I would like to thank you for your time and for listening to us. And if you have any questions and you think those questions could help all the audience, then please ask them now. Otherwise, we're happy to take individual questions after the end of the talk. And thank you very much for listening.